Hello, everyone, and thank you for joining us for another episode with HDC Chat Series. And today we have the pleasure and honor of having Dr. Aziz Benbrahim joining us. Thank you so much for being here with us.
All right, thank you, Rashida. I want to just warn you right now that my AI knowledge is very limited. Okay, so no, it's
There
based.
is so much you're bringing to the table, and that's why we're having you. You're just being very extremely humble. I've seen you in action, and I'm going to talk a little bit how we met and the areas where we work together. So you're just being very humble, just like all the leaders around the world, and that's something you all have in common. So thank you for again for joining us. For audiences, just a little background. HDC is a mission-driven platform where we host special guests and speakers from around the world to share their experiences and groundbreaking insights of the convergence of healthcare and digital innovation, and of course, including AI. As usual, I read a short bio about our guest speakers, and today we have Dr. Aziz Benbrahim. He's a surgeon and medical director of bariatric at Hartford Healthcare. He's also a professor of surgery at Quinnipiac University. Over the last 3 decades, I'm aging you a little bit here, of surgical experience, he has pioneered minimally invasive and robotic bariatric techniques. He led patient-centered programs and contributed globally through education and surgical mission. Again, one more time, thank you for joining us and accepting the invitation to be a guest speaker at the HDC Chat Series.
Thank you. I'll be calling you Rashida, okay?
That's fine, absolutely. Um, with the first question, I think I always start with something light or personal. When I met you for the first time, we both have a joint appointment at the Frank Nutter School of Medicine at Quinnipiac University. And I was amazed when I heard about your background, your experiences. I'm going to start with that. Your career is spanning, I think, 3 continents. I'm going to name few countries: Morocco, France, and then the U.S. of course, and then talking about some of the organizations that you worked with or acquired extra knowledge will be Harvard, Yale, and Quinnipiac, and the list goes on, of course. In what ways these experiences shaped your views on healthcare innovation and global collaboration? I know it's a mouthful or question, but you're up to it.
So I was born in the desert of Morocco, where the closest hospital was about 200 miles. And they have seen tragedies. And from the beginning, I was thinking in my teenage years that probably medicine will be a path to at least try to fill the gap. And went to Casablanca in the medical school. That's where I had my degree. And early, the early days in the operating room and in the hospital, I could see the resources needed in a place like Morocco at that time. And thank God things have changed since then. And I just felt like I wanted to go and continue my career. I went to France, and actually, my career is not 3 decades, it's 4 decades. The first day I was on call in the emergency room, it was Christmas Eve, 1986, in the south of France. So the French experience after my thesis in medicine allowed me to see even further. And in the early 90s, I left France and I arrived to Boston. And then I had the privilege to join Mass General Hospital and do research there. And the beauty of it is when I met Bill Abbott, who was the head of vascular surgery there, he said, have you done any research before? I said, no. He says, do you want to get paid? I said, no. When do you want to start? I said, now. I said, okay, show him the lab. And it was one
Amazing.
of the magical 3 years of research. And I filed for 3 patents. And just a personal note, It's based on that I had the Harvard sponsor me for my green card, and that's how I got my my citizenship later. After that, I worked with MIT and Harvard in one of the projects, and there was the idea of continuing doing that. But I felt I really missed a human contact with the patients. So, and I did not want to stay in the lab. So I went to Yale at that time, and they redid all my surgical training. Then I finished in 2000, and that's how I started practicing.
What an amazing and inspiring journey. But what caught my attention is one sentence you said, do you want to get paid? And the answer was no. This is, nobody would say no to getting paid that I know of or have ever met. So that is really interesting. I think I'm going to push more buttons while you're turning down money. Um,
Well,
uh,
I'll tell you, it's not actually, I was preparing for my equivalency exam in Boston, and I met this gentleman from Spain, and he said that you don't have any experience in the States. It will be very hard for you to get into it. And they said, but what should I do? He said, what do you want to do? At that time, I said, I wanted to do vascular surgery. He said, okay. Go to Mass General and tell them you want to work for free. Nobody will say no to a doctor. But he knew that by the time when I started about 3 or 4 months later, I got paid. So it's not like, but that was a friend of mine who gave me the right mentorship in order to get into the system.
We need to talk later on about mentorship and the importance of keeping the human contact in the age of AI and digitization. Um, you said you did your training when you got to this area, New England, back to surgery. What inspired you? You're known for bariatric, I can't pronounce that word,
Bariatric, yeah.
surgery, bariatric surgeries, and you're pretty renowned from many people that I heard of. What inspired your deep commitment to this type of surgery and surgical education?
Well, I was supposed to be a vascular surgeon. And as a third year resident, I saw groundbreaking technology, and they have some background in engineering in the past. And I saw a radiologist putting a stent into an artery, and the patient went home the same day. While this required big surgery, patient staying for a week or so in the hospital, and they said, okay, this is not the vascular surgery I want to do because I am seeing it changing completely. At the meantime, my chairman was one of the pioneers of bariatric surgery. And when the chairman does something, all the residents have to do what the chairman does. And
That's right.
he was an incredible surgeon. So I have switched to minimally invasive surgery at that time, which was laparoscopy. I finished my residency, and then 3 years later, and this is a very interesting story, if I may.
Absolutely.
3 years later, I am in my office seeing patients, and I was told that there was somebody who wants to see me. He didn't have an appointment. I said, I don't know this person. And he said, no, he knows you. And when he comes in, I could not recognize him. He was a patient. I did his surgery when I was a chief resident. He was 800 pounds with about 13 or 14 medical problems. And when he came to see me, he was 250 pounds. And he didn't have any medical problem, but some heart issues and knees. And he said, you did my surgery. I said, yeah, Dr. Reinhold did it. I said, no, you did my surgery, and I thank you for that. And I want you to start a program at your hospital at Mid-State Medical Center, where I am right now for the last 23 years or so. I said, you are kidding me. This is a small hospital. I cannot do that. I said, no, I'll help you. Unfortunately, he passed because after many, many years because of his heart issues, and that feeling I could not let it go. And the following year, I started the program. And that's really, and since then I have been training other surgeons or helping other surgeons in bariatric surgery.
I always try to get examples and illustrations about the expertise of my guest speakers, and I'm so glad you gave this inspiring experience from your point of view as a medical doctor, and hearing that from your own patient. That, of course, you see so many, but coming back and telling you what a difference you made in their life is just mind-boggling. Going back to bariatric surgery, a lot of our audience, especially from the AI side, do not understand a lot about medicine, just like our medical professionals and students, they understand more of the medicine and not the AI side. Can you expand a little bit more of some of the greatest advantages of using robotics in surgery, and what it brings to actually patients, beside the example, the wonderful example that you just shared
Yeah.
with us?
So first, bariatric came from the word baros, which is pressure. But bariatric surgery meaning surgery for obesity. And it has been in existence for almost 70 years, 70. And it went through many stages, and there are many surgeries many techniques that come and gone. And patients, it is so far the best way of treating severe obesity disease. Medications exist like Ozempic and so forth. However, they are not as effective as surgery. As far as the robotics in bariatric surgery, that has been a milestone. Because when we are dealing with a patient who has severe obesity, they have a very large abdominal wall, and then when we put instruments, it's very hard to work against that pressure. The robot takes that into account, and the surgeon is not as forcefully doing surgery. Therefore, the manual dexterity through the robot is much better and more precise. That's one part of the robot itself. The other part is the robot has a 3D vision, which is one incredible vision. And obviously, surgeons are like obsessive compulsive. With the robot, I control everything. I control the camera movements. I control with my feet, with my hands, everything I need, as opposed to having an assistant doing that. And so that's it. The third point is we are collecting data. And the robot collects every single move I do, every single instrument I use. I receive in my app, as soon as I finish, I receive not only the information, how long it took me, how do I compare with myself, how do I compare with the rest of the US surgeons for the same surgery, and how do I compare with the 10%, the best surgeons in the country. So that's really an incredible data we can use for teaching, we can use for self-improvement, but also we can use for almost democratization of the technique itself. So that's how I see as part of the robotics in bariatric surgery.
So there is already a lot of machine learning that compares you to others, that compares you to yourself and other surgeons around the country. Do you see robotics and AI working together to advance surgical precisions and patient safety?
Absolutely, no doubt in my mind. I lived through, in my early years, I lived through the late 80s when laparoscopy became something new. Besides the precision and the technique and stuff, there was something very important. Open surgery, the surgeon is looking at the field and the assistant is looking at it, and that's it. Laparoscopy, now we can record the video of every single thing is happening. Now everybody can see that. So now we are seeing the good, the bad, and the ugly. And then we are learning. Now we have that pressure different than just a surgeon having their hands in the field. And that's what laparoscopy did. At least we have that video signal, generated video signal. Now the robotic exploded with more than than not only the video signal. Now you have every single, the dexterity, the ergonomics, the time. And because of that, I want to bring you to a study
Please.
in about 10 or 15 years ago. Blue Cross Blue Shield in Michigan. I may not be very, very precise, but this is the gist of it. In Michigan, they called the local bariatric society, the surgeons, and they told them, listen, guys, we don't understand. There are some surgeons who cost us $20,000 per case, and for the same case, other surgeons cost us $200,000. Here is what we will do. We will give you this number of, we'll give you this $8 million or so, and we want you to do a study for us and just tell us what to do to fix this. And they said the Michigan State University is the one who will hold the data. So we don't want the surgeons to manipulate it. That's number one. Number two, we want every single surgeon to participate in it. And guess what? Every surgeon thought he or she was doing well. So what they did, they asked every surgeon to send a video of their surgery. How do you do gastric bypass? Or how do you do the sleeve? We don't care, easy or not, just tell us how you do it. Without the name, we don't need to see your name, we don't need to see it. And then they send it, and then they send it to all the surgeons. All the surgeries to all the surgeons, and they ask them questions. These are the steps of this surgery. Let us know which step you like the best. Okay, following me here? So now,
Interesting. They're reviewing other surgeons' methods of
yeah.
to.
And then there was surgeons said, wait a minute, I don't do it this way, but I like this. So at the end, they had a composite of how to do gastric bypass based on the voting. All the surgeons said this technique is the one we would like to do. Now, before doing that, they had already the graph of all the surgeons, the ones who have the most complications and the ones who are costing the most. And there are some surgeons who thought they were good, but they saw themselves in a very bad shape in that graph. And then after they went to all the surgeons and said, we want you to use this technique, all of you. And the surgeons who were the worst, they found exactly one part where they fixed that and they became one of the best. Not only that, the ones who became the best became mentors to the ones who were not great. And Blue Cross Blue Shield got their money back, I think, in the first year or so for the money they gave. So
Amazing.
and this is one of the best studies for me in surgery. So, and this was done with a lot of cumbersome data and stuff. If we have all the data through robotics, we can very quickly understand what's working the best. And not only that, but the robot immediately while we are working can indicate to us, okay, you are doing this way, probably think about doing it differently. And that's probably will be like almost like a continuous mentorship from thousands of surgeons who have supplied their data before, as opposed to just having one surgeon with you, not all the time. So that's what I see the interest in this.
This is an interesting study, and thank you for sharing it with me and the entire audience. I'm sure everybody's going to look at that study. It's extremely inspiring, and you started, it's all about the data. They could not make any of those changes or those recommendations had they not have access to that data and the willingness of all the surgeons to participate and then review others and other techniques and make recommendations.
If I may, just one more point about this study. Before that, in order to be a center of quality for bariatric surgery, you needed to do 120 or 150 cases a year. I was in a small hospital, I could not do it. And then there was a catch-22, because if you are not center of quality, the insurance will not allow you to do the surgery.
Interesting.
this study has shown that most of the programs that were doing only 50 or 60 a year had much better results than the programs that were doing 300. So the center of quality changed from the center of excellence based on numbers. This data showed, no, it's based on quality of care as opposed to the numbers. So that idea of the volume is always good, not necessarily. And that's why I want to make that point.
It is interesting that a lot of AI projects are based on what you just described. And this study allowed to see, well, first, there is a lot of buy-in from different stakeholders, and then they saw the ROI. There is a return on investment, as you said, within a year or so. They saw that. And you said one of your wishes is to have AI tools, techniques as you're doing surgeries to make recommendations, or what we call to augment or assist the surgeon while doing surgery. Is this something that you see happening in the near future, where you have all this data that you already share about you, compare others, and it will tell you, okay, Dr. Benbrahim, as you're going here, there will be something flashing on your screen. Okay, it will be better if you do sutures here, or if you move to this right or left, or do another techniques. Is this something you think it's happening? It's already happening or about to happen?
Already happening. It's already happening, and then, but not at the clinical side yet.
Okay.
Also, if you have heard, just like last 2 months ago in Baltimore, a robot did a complete surgery in a pig, a complete surgery without human intervention of removing the gallbladder.
Did the pig survive?
Well, that's really surgery. I don't know about that.
Sorry,
Not the surgery itself. Yeah, the surgery itself was a success.
success.
So now this is definitely happening everywhere. And not only that, now we're having not only the augmentation, we are having the robot analyzing the structures and giving them a color. Like, for example, the artery will be look red in the screen, the vein will look blue, the biliary system will look green. So now the surgeon who is working will see exactly all the organs in a different colors, which will be very unheard of and incredible for the safety and stuff. So
How you have, and you had many leadership roles. What challenges do you anticipate in introducing AI solutions similar to the one that you just spoke about across healthcare systems? What challenges?
I am still having the PTSD from the electronic medical records.
I think every other doctor.
I spent 3 hours this morning with the electronic medical records team to try to fix my chart and to make it a little bit palatable to me again, while we have it for 10 years. The reason I'm saying this, the goal of the electronic medical records was for billing and auditing, was never for patient care. So we are retrofitting it, but by doing that, we created so much work for the team, so much work for everybody, and it's extremely difficult to extract the information we want. And the reason I'm saying this is, yes, AI will be great. However, we have to rethink it, and we have to make sure to get the buy-in of people, get the ethics of it, make sure we are really knowing where are we going with it, and using it as not as an end product, using it as a device just to buffer the deficiencies of our care. And in the beginning, because I really think that whenever we introduce any device to healthcare, I think we need to be very careful and do it slowly, get everybody involved, from anybody in the team. The top-down way of doing it is not the right way. I think we have to assess the needs first, and then from the needs, we can create solutions. You want to buy me a jacket, that's fine, but if I don't need it, there is no reason to do it. And similar for here, we really have to be very careful with that. From the experience of the electronic medical record, I think we need to slow down and think twice.
I did a study with our common friend. I'm going to mention her name, Angela Maddie, who has
Oh,
a
best
JD.
friend. Yeah.
Yeah, our
Just,
fantastic common friend.
just was with her at the university today, so.
Yeah. We're working on study. We're wrapping up that study where we interviewed over 30 experts in the field across the United States, from small, large hospital, government, and we're putting together a framework. And you mentioned part of that, it starts with data. When you don't have enough data or not a good quality of data, everything else kind of falls down. But there are other components besides just the model itself, whether it's the AI strategy, the buy-in, the ethics out of it, the human aspect. And we put together a framework. Of course, I'm not going to share it here because this study is not published yet. So hopefully soon. But I'm shifting to combining those in one question. If you were designing from your medical expertise and how you're practicing, but also you're educating the next generation of surgeon, if you were designing an AI augmented bariatric program from scratch, what core capabilities would you include for patients, surgeons, and support teams?
Yes. That's a really great question. I drive a Tesla, and when I put it on automatic pilot from here to New York, it's great when 95 is not very busy. It's great. The AI system, the car, whatever the technology is taking care of it. But when I arrive to downtown New York, I need to get involved. That's really when it becomes very complex. This idea of my brother, but that's another story. It is when it becomes very complex, then you need to take over. So the other example I want to give, the gentleman who landed in the Hudson in 2009, Sally, if you know the story, a lot of technology was in that plane. Not only the technology, but everybody in his crew was taking care of whatever they needed to do.
Okay.
And all what he needed to do himself is to concentrate on one action. He's the only one who can do it. That's the human part of it. So going to your question, I would like AI to take care of the science in medicine. Medicine has part is science and part is art. I want to take care of the science and with the tangibles, with things we see every day, the chart of the patient, what are the medical problems the patient has, and what's the type of education they need, all the medications and all that stuff. The AI, if the AI does that, and then I sit down with the patient and they have that human contact, and all what I need to do is to talk with the patient and discuss with them what we will do, that will be a very, very big success already.
That's a great example, talking about how we can incorporate the human aspect as well as the technical aspect of AI and leave the practice of medicine and the empathy to medical doctors. Talking about medical doctors in the future, emerging surgeon, what advice would you offer to the upcoming healthcare leaders and surgeons to safely integrate AI into practice, at the same time, what you said, preserving the human connection and high quality of surgical education, especially that you're professor of surgery at the Frank Netter School of Medicine?
I'll give you an example. We stopped since COVID, but every year we used to go to Ecuador for a surgical mission. And we went there and we started at 7 a.m. and we finished at 11 p.m. We used to do surgery on the indigenous people, the Quechua people from the Amazon there. And we'll do many, many surgeries with extremely limited resources, one team, one room, and at 11 o'clock at night, we're still not tired at all going for dinner. Here in this system, I will do half the work, and I am extremely exhausted. Why? Because we have a plethora of data we don't need. There, I had one page for the medical record of the patients. The name, what are the symptoms and the physical exam online, what the procedure I did, what did the anesthesia do, and discharge. There was no burden, no administrative burden at all. So if the AI takes the administrative burden out, that's already will allow our new surgeons in the future to concentrate on the human part of healthcare delivery. That's one thing. Now, obviously, that ship has sailed. AI is here to stay, just like laparoscopy was here to stay when people were resisting it. It will be included in every single thing we do, and they think it's absolutely great because it will leapfrog other countries who are not as advanced. This is just like the example of the phone. The phone was a luxury, but now we have a cell phone everywhere in the world. I think AI will create that. And AI will allow any surgeon learning anywhere to see the latest techniques as opposed to flying somewhere to see a surgeon doing some weird thing alone. So that's really, that democracy of knowledge and democracy of technique will help all the new surgeons, and they need to embrace it 100%. They just have to keep their critical thinking. It's so important. And then if we do that, then I think we'll be safe.
You mentioned almost catch-22. You have a lot of data, but at the same time, you're missing information. And we cannot have, I won't say, operational AI systems if we don't have enough data. Yet on the sidebar, I'm not going to say really on the side, you did a lot of mission, a lot of them volunteer in South America, in Africa, and you worked with less resources, less availability of data, yet the data helps you to compare with other surgeons around the world and how you are doing. So if you can further explain, do we want less data to be able more operational, or more data so it augment and assist you in future surgery and see how you can take care of more patient and do even better? If you can.
There is a good data and bad data, as you know. We need all the good data, as much data as we can. That's absolutely important. That's how we will help. That's how we know. That's how we'll have even the peer pressure. That's how we have every single thing. This will create a transparency in surgery. That's absolutely a lot, but we need a good one in a way that we can exploit the data and create more processes in order to do safe surgery. Now, we have to be careful with the collaterals. I have my iPhone, it's great, but if I am stuck in Facebook the whole day, then there is so much data and I'm not using it in the right way. So that's why I don't know how to explain it, but I need AI when I need it. I don't need AI to be imposed on me. And in a way that, but ultimately we will go through a period of gathering data, processing it, and then the output will be a streamlined techniques. Now, I don't know the percentage of science in medicine right now, maybe 30%. The rest of an art of medicine doesn't mean it's bad, but we don't need artists in medicine. If AI can switch that paradigm, that will be great. And it's happening. Yeah.
That's really interesting. The combination of always having a joint appointment in school medicine. I always hear that percentages between science and art when practicing medicine. Um, I'm going to switch to, you mentioned earlier that AI initiatives, the means buy-in from a stakeholder or from top-down approach for it to take place, right? But at the same time, I'm not trying to trick you here, by the way, but at the same time, the users, whether it's doctors doing surgeries or other radiologists, is this meeting your individual needs as a practicing doctor? Because when we look at AI strategy, it may not be going all the way down to you operating on a patient. Is there any disconnects from the top down to the bottom up approach? I know I'm moving more to strategy and operationalization of AI, but if you can share some insights to illuminate some lights as we see a lot of AI initiatives being stuck. And if we just look at the data everywhere else around the world, it's stuck somewhere. We are investing in so many models. The technical models or the statistical models are fine. We have some of the best all around the world where they training the models and it's great, but then when it comes to applying it and operationalizing it, there is a high level of failures, and the data is showing so. There are certain pockets, I'm not going to say all of them, certain pockets where it's thriving, but others it's not. So if you can shed more insights on where the bottlenecks, is it really top down when it comes to buy-in and bottom up with regard to something else? Waiting for your insights if you can shed some light there.
I think we are in a transitional time. The transitional time is everybody wants to make a buck from AI. So on that, so everybody is coming, I want to sell you this, I want to make this green and this blue. And so we have to wait until this wave goes away. The clear example is radiology. Radiology, for many years now, the radiologist at night in my hospital don't read the CAT scan. The CAT scans are read in Australia or India where they are awake at that time, which is good for the patient. You don't have a very tired radiologist. So the data is there. So AI can now read the CAT scans and come, if I were a radiologist, will come and tell me, hey, the 10 scans you want to read, number 7 is the one who has an issue. Look at it right away. The other ones are normal, but you can look at them later. So that's I think it's slam dunk. I mean, if radiology doesn't accept this, then there is another story about that. The same thing for primary care, because remember, from what I see, the radiologist and primary care, what do they do in general? They process data. And then when they process, however, their process data is based on very limited experience compared to the world. They process data because they saw 1,000 CAT scans in their life. However, they are tired now. Somebody is calling them on the phone, distracting them. So their output can be not as good as if they are at 7 a.m. just wake after their coffee. The same thing for primary care. The primary care they tell the primary care, you have to see the patient in 15 minutes. When you open the electronic medical records, unbelievable how you need to go through to just find what you are looking for. and you see that it's there either because of medical legal or billing or so. There is very rare now you can find something simple that tell you Mr. Jones was here for cellulitis of his leg and he needs this. You don't find this narration we had before. So if you have AI checking Mr. Jones when he comes in, this AI, this is what the process does. It has all the information about the patient. This will only answer your interrogation. This patient is here for high blood pressure. It will give you only that information. And then when you want to give the medication, where do you get that information from? You get it from what you have in your head. How many blood pressure medications you would remember? How about the guy who sells it, who just came by and then says hi, and then he's basically pushing you to prescribe it. AI will tell you this patient takes 12 medications. Their interaction is this, and that. Therefore, this is the medication you might be given. And by doing that, now you have a physician sitting with the patient, doing there's empathy now, and really taking care of the patient. I'll give you a very simple example in my practice. Patient comes to see me for one thing, and I sit with them for a while and talk with them and have conversation, and then I find out that they have something else. So if I am pushed with time, I might not give a good care. So to go back to your question, yes, radiology, yes, primary care. For surgery, it's still a little bit tricky. However, I don't think it's far from reality right now. And I'll give you an example, especially with robotics. We had some surgeons who used to do open surgery, and open surgery is painful, and they were having complications. When they switched to robotics, they became almost like every other surgeons, having almost the same results, because there's almost only one way of doing it. However, again, unfortunately, the human factor has two things, the positive and the negative. If you have, it's not the technique. The technique you can teach people is the lack of judgment. And if there is a lack of judgment, AI will not fix that. So that's really, I hope I answered your question.
Yeah, well, I have a big question mark, and I know I'm using your time about the lack of judgment, and it seems we are going toward the direction where AI may have some judgment in the near future. But and that probably takes me to the next question. I know you're a big supporter of AI to augment healthcare delivery, but there's some ethical biases and other concerns that come with the use of AI in healthcare delivery. Which ones concerns you the most?
If I am teaching a new surgeon, and this new, I will tell the surgeon, this is how I do this technique, based on my experience and based on my outcomes. But let's say the surgeon will just follow an AI model that will tell him how to do it. Okay, this AI basically says this is the best technique for that, and this surgeon will follow it. Even if it's based on data of good data or so, the surgeon is still liable for what he or she is doing. So as long as we consider AI as a tool like any other tool, when I have a knife in the operating room, I know where to cut, and I cannot just cut everywhere. So same thing for AI. I think it's a great tool like a knife that allows me to go help a patient, but it's extremely dangerous tool if I don't use it the right way. And that's how and after we like in an old French movie, we have to see clear in the confusion. After the confusion disappears of all
That's right.
the innovation, the money involved, the technology, after all that settles down, I think AI will be of great things. So to go back to your question before this one about why it's stopping somewhere, it's stopping because of it's so overwhelming. It's so overwhelming, and everybody wants to do it, and everybody's looking at it differently, and the doers, like I say, sometimes I'm a doer, sometimes I'm a leader, sometimes I'm a follower. I have to know where, and the doers like me will not really embrace anything right away until we see the results, until we see the studies on it, until we see that it's really all the societies that lead this type of surgery or so should really do a good studies before just putting it in the open. And it is really interesting in a way, but at the same time, I would caution of using it right away until we make sure it's correct. One more thing, the engineers who are involved should analyze what we do in the OR before coming up with ideas. And
Absolutely.
that's really very important.
Yeah, I think it's definitely a collaborative environment. You can be the best AI developer, but if you don't understand what the field you're providing models, then you're not doing justice. And the same thing, I think it goes for a medical doctor or practitioner that does not understand the power of how this could augment, that will be left behind. I think I'll have one more question. Well, I have like 10 more, but I know you have surgeries in the morning, and I'm going to be mindful of your time. Every great surgeon, and you're one of them, brings something unique to their art, to their craft. What is your signature move or special sauce you believe sets your work apart, including or not including AI?
Um, I think empathy. I'll tell you, I did surgery on a patient about 2 years ago, and he or she lost about 100 pounds. And she came to see me because she gained a little bit of weight. Very depressed. And I drew the chart of her weight loss. I showed her that all her medical problems have resolved. She had sleep apnea, diabetes, all of that is gone. I showed her also that her mobility has greatly improved. Now she can go in the roller coaster with her 6-year-old son. She can do stuff. She's doing yoga. She's doing a lot of things. She could never do that. And they said, as far as I am concerned, you made my day and you are a big success. And she said, I know that. I just want to be here to hear it from you. And that's really what makes what we do. That's empathy and sympathy and having that the human part always our beacon or what we do. I think it's that has not only good for the human part, it's also good for business. It's good for lack of litigation. It's
Yeah.
good for every single thing when you do the right thing. And that's really what I have been guiding me all these years in my career.
I have one more comment is um, you were wrong. You were very wrong when you said you don't know much about the conversions of AI and medicine and healthcare. And our conversation for the last more than 45 minutes showed that you are just like any other great leader, humble about your knowledge, but not afraid to share it with all of us. So, for that, thank you so, so much for sharing insights, for being humble, for educating, and just being a great advocate for sharing knowledge.
Thank you so much, Rashida. I'll call you Rashida, Professor Parks. But I think what you have been doing is incredible. Thank you for reaching out. It puts us in a situation to understand what's going on instead of being in the dark, talking with people like you, expert in AI. And I am really hoping that our paths will cross again.
Absolutely. Thanks again. Hope to see you soon in other episodes of HDC Chat Series and other events within Quinnipiac University.
Disclaimer. The views and opinions expressed in this podcast are those of the presenter and do not necessarily reflect the views or positions of the organization or entity represented by the presenter.